Thank you for very impressive lecture from the endoscopic part. Now we move on to the next sections, interplay and cooperation of H. pylori and gut microbiota formed management of clinical disease. We warmly welcome Professor Varocha Mahachai as our moderator. Professor Varocha Mahachai now serves as committee member in various international societies, council member, chairman award committee, Asian Pacific Gastroenterology Association. Dr. Mahachai served as an editorial board of H. pylori and JNM. Please join me welcoming Professor Varocha Mahachai.
Thank you, Dr. Navapan. And now it's time we move on the next symposium. First of all, I would like to thank Bangkok and DKSH for making this educational program possible. And what we will hear in the next 1 hour is a topic on Helicobacter pylori and gut microbiota for management of clinical diseases. And we're fortunate to have two outstanding speakers. And the first one, Professor Francis Mégraud, and everyone knows him from different meetings. Dr. Francis Mégraud is a professor of bacteriology at University of Bordeaux, and he's a head of the laboratory of bacteriology. He's one of the founding members and current secretary of the European Helicobacter and Microbiota Study Group. And his main current interests are role of Helicobacter in gastric cancer, and he's a key world leader in the field of antimicrobial resistance. He will speak to us today on the topic of Helicobacter prevalence, diagnostic, standard treatment, and the side effects, including benefit of probiotic in the prevention of side effects. So please welcome Dr. Francis Mégraud.
Thank you very much, Mrs. President. So first, I would like to thank the organizers, that means you, Varocha and Maneerattanaporn, as well as the company DMKS for their support and welcome in Bangkok. So I will go through these different topics now. My declaration of interest, you can see. So first, a few words concerning prevalence. You already saw this map, which was published 5 years ago, yesterday, for example, presented by Varocha. So 2 points. First, a lot of gray. That means area where we don't know really the prevalence of the infection, mostly in Africa. And also the second point is a lot of heterogeneity concerning the prevalence. You can see the dark colors, more than 70% prevalence, and the close to yellow is less than 40%. If we look especially to this our area where we are, Vietnam has the highest prevalence, more than 70%. In Thailand is less than 40, is about 40 to 50%, and Malaysia is even less. A long time ago, when I was having a strong collaboration with Vietnam, we did a study about the seroprevalence of H. pylori infection, including Vietnam, as you see. And already at this time, there was more than 70% prevalence in adults. So in fact, it seems that it didn't change much during these 30 years. When this infection is acquired, there was this study concerning the seroconversion of H. pylori in a cohort of 224 children followed during 20 years in Louisiana, in USA. You can see that the acquisition, seroconversion decreased in childhood during these different years. And is the maximum at the younger age, and when you reach the adulthood, virtually there is no infection, no new infection, only very few. So how is it acquired? Mainly in the family. And in this Italian study, they showed that if you have two parents infected, you got the children have the highest rate of infection, 44%. If only one parent is infected, it decreased to 30%. And if no parent infected, it decreased to 21%. You see, but it means also that all is not acquired in intrafamilially. There is also a possibility to acquire the infection outside. And you can see that if you have only one infected parent, the role of the mother seems more important than the father for the contamination, which is understandable concerning the more intimate relationship that there is between the child and his mother. So the main risk factor altogether is a low socioeconomic status. And what does it mean with regard to H. pylori infection? It means small houses, large households, low income, low education, and in addition, lack of facilities, especially for hygiene, lack of access to water, for example. So now we move to the second part, which is the methods for the H. pylori detection. As all of you know, there are two types of these methods. The invasive test, which need to get gastric biopsies, which are obtained through endoscopy, and it includes histology, rapid urease test, culture, and real-time PCR. And the non-invasive test, which are urea breath tests, specific for H. pylori, stool antigen test, serology, and also, but not as productive as a urinary test and salivary test. So I will go just give the value of the different methods. For histological examination, there is a good sensitivity and specificity. There is no problem with regard to the transport of specimen. It has the added value of the examination of the mucosal status and the possibility also to predict the risk of gastric cancer using the whole-gas staging or the whole-gym staging, which have been proposed. I must say also that they can detect clarithromycin resistance if you use a special FISH method, fluorescence in situ hybridization method. But the side effect is that they are dependent of the qualities of the biopsies and of the experience of the observer. Concerning the rapid urine test, is a test, the advantage is to be performed in the endoscopy ward. The limit is at only about 80% sensitivity within an hour. But if the result is positive, it allows to prescribe a treatment immediately. Value of culture, good sensitivity, maximal specificity, because you have the bacteria you can test in any way. And it has the added value to perform antimicrobial susceptibility testing for all the antibiotics which can be used to treat H. pylori infection. But it needs specific transport condition, motivated personnel in the lab, and also the result come after several days. There is always a long delay before to get the result. So I introduce here the question of macrolide resistance. You can see this occurs when there are mutations in the 23S ribosomal DNA, especially at this position in domain 5, where you can see that some adenines can be replaced by guanine or cytosine at this position, and this leads to a decrease in the affinity for the target. So based on this data, there are design of a specific real-time PCR to detect first H. pylori and second, the mutation which lead to a macrolide resistance. And So this method, named the so-called FRET MCA, or fluorescence resonance energy transfer, and melting curve analysis, real-time PCR, needs no more than 2 hours to get the result. You have the first hour to prepare, extract the DNA, and the second hour just to go in the light cycler. And so you can get a result concerning first the presence or absence of H. pylori, and second, the presence or absence of the mutation associated with clarithromycin resistance. So this real-time PCR has an excellent sensitivity and specificity. It's better than all the others. There is no problem for transport of the specimens. The result is quick, as I showed you. And also, as I mentioned, it has the added value of the possibility to look for mutation associated with clarithromycin resistance. Now, concerning the non-invasive tests, the value of C13 uroBT, excellent sensitivity and specificity. It's really a non-invasive test, easy to perform. There is no problem of transport of the specimen. You get an objective result. There is no human interpretation. But the limit is that you need to have a mass or infrared spectrometer, which is not the case in any laboratory. And also the result is quite influenced by the presence, the consumption of proton pump inhibitors. Indeed, it is essentially used for the control of eradication, a minimum of 1 month after the end of therapy. It can also be used, as it is sometimes, as a primary diagnosis in young patients without alarm symptom in the context of a test and treat strategy. Stool test has the advantage to give also result very close to those of the UBT, even for control after treatment. Can be performed in all laboratories. You don't need this special material. And there are even now new formats, so-called immunochromatographic tests, which are very promising, but improving year by year, but not fully at the same levels as ELISA at this stage. Serology has the potential advantages to be the only test which is not influenced by the changes which can occur in the stomach. Indeed, the bacterial load can be decreased under the threshold of detection by using the over test. It can be transitorily in case of antimicrobial or anti-secretory consumption. It can be permanently in case of pre-neoplastic or neoplastic lesions. So the value of serology is to be used as a non-invasive test in young patients in case of impossibility to stop PPI before to perform the test. And also it can be used when you want to perform organized screening in the general population, but never for eradication control, because indeed H. pylori specific antibodies decrease very slowly after eradication and can still be present months and even sometimes years after eradication. So I must add to this test meta-analysis of studies detecting H. pylori and clarithromycin resistance by real-time PCR or by PCR in general on stools. Indeed, there was this meta-analysis reported 11 studies performed in 7 countries, 5 used nested PCR, 5 real-time PCR, and 1 GLOT Pellico DR. And apparently the sensitivity and specificity were over 90% for detection of H. pylori and clarithromycin. So it's interesting for the future. There are other molecular methods, such as PCR with sequencing of the PCR products, which can be used for resistance to quinolone by sequencing the GIR-A gene, or RPOB for rifabutin, 16S RNA for tetracycline. There is a droplet digital PCR, which allows quantitative results, is able to detect low density of H. pylori, can also be used in stools, and detects also H. pylori clarithromycin resistance. And least, the next generation sequences. So currently is more a research tool than a routine method. It allows the exploration of the mutation associated with H. pylori resistance to all antimicrobials such as metronidazole, amoxicillin, fluoroquinolone, etc., and macrolide. And it can be performed on formalin-fixed biopsies and also on stools. So in conclusion, for the diagnostic methods, we can say that we currently have easy molecular methods to measure and monitor H. pylori resistance to antibiotics. We can apply especially real-time PCR for clarithromycin, because it allows to perform a guided treatment and to limit the adverse events of the antibiotic. NGS is still to be used for research purpose in my mind, but may become routine in the future. Oh, would you like to share your stomach with him? So we go to the treatment of H. pylori. So I will present you the basis for the treatment. First, we need to use powerful anti-secretory drugs in order to obtain a chemical stability of the antibiotic, optical efficacy also. As you know, the pH of the stomach is quite low, so it's why we need the best PPI, and even better now with the PCABs, especially vonoprazan. You can see on this slide some of the difference in MIC according to the pH. And you can see, you can see if you go to pH 5.5 to pH 7.5, you decrease the activity of ampicillin by 10 times, also almost the same for clarithromycin. It's not true for metronidazole, which is stable, nor for bismuth, but it's interesting that amoxicillin or ampicillin and clarithromycin are very dependent of the pH. Second, we need to use absorbable drugs in order to obtain a long-term effect of the antimicrobial compound. There is one exception, it is the bismuth salt, which act topically in the stomach quickly on the bacterial cell wall, in contrast to antibiotics, which have a long time for action. We need to have drugs with an intracellular diffusion. This is not the case for amoxicillin. Amoxicillin has a paracellular diffusion through the epithelium, that means between the cells. Clarithromycin, in contrast, go inside the cell, lead to high intracellular concentration, which is progressively released in the mucus, and so allowed to have it only given twice a day. We need an association of antimicrobial compounds to obtain the maximal efficacy to avoid resistance selection. Is the same which occur with, for example, mycobacterial tuberculosis. We need an association. We need oral drugs for practical and cost reason, because H. pylori is usually treated ambulatory and patients are usually still in activity. So it's important to have oral drugs. So these are the main regimens which are currently available. You have the standard triple therapy with PPI clarithromycin, to which you can add either amoxicillin or metronidazole. You have the bismuth-based quadruple therapy. You have the levofloxacin-based triple therapy, the quadruple therapy without bismuth, that means using three antibiotics, so-called concomitant treatment. In fact, the tendency is to limit its recommendation because of the impact of these three antibiotics on the gut microbiota and the selection of bacterial resistance. to be in line with the prudent use of antibiotic guidance from the WHO. And we have also the rifabutin-based triple therapy. So this last year, we tried to privilege the optimized triple therapy. That means the use of clarithromycin to be used if there is, after clarithromycin testing, we're showing a susceptible strain, to prescribe preferentially a PPI not concerned by the rapid metabolism. That means via the CYP2C19, that is esomeprazole or rabeprazole, to use a double dose of PPI. It can be now vonoprazan if available, and use preferentially 50 milligram per kilogram of amoxicillin given 3 times or 4 times a day in agreement with the pharmacological properties of this antibiotic during 14 days. So this is a possibility for first and second line H. pylori eradication. So you perform a real-time PCR on gastric biopsy or eventually on stool. If it's susceptible, you use this optimal triple therapy, and in case of failure, you go to bismuth quadruple. If you have clarithromycin resistance, you go directly to bismuth quadruple therapy, and in case of failure, you may use a levofloxacin-based triple therapy. And if you really cannot use antimicrobial susceptibility testing, which is difficult to believe now because, as it was said yesterday, following the COVID, any hospital has a possibility to do PCR now, and there are kits commercially available for H. pylori, so it's the same techniques than for COVID. So I think it should be now very exceptional if it's not possible to do this antimicrobial susceptibility testing by a real-time PCR. But if it occurs, you go directly to bismuth quadruple. So is it possible to improve these eradication rates obtained by adding probiotics? What are the probiotics? And just I remind you that are living non-pathogenic microorganisms administered as food supplements which induce health benefits to their host when ingested in sufficient quantity by altering the microbial balance. And the prebiotics compounds able to stimulate the development of probiotics. So there are conditions required for a microorganism to be used as a probiotic. First, it must be resistant to gastrointestinal juice, biliary salt, and to a low pH. It must adhere to the digestive tract mucus, and also it must not be able to transmit genetic elements concerning antibiotic resistance. So here are a long list of microorganisms which have been used as a probiotic. You can see they are in mainly bacteria, in the genus Bifidobacterium, in the genus Lactobacillus, other genera such as Bacillus subtilis, Closi, Escherichia coli strain Nisley, also Streptococcus or Enterococci. But there is also another one, which is a yeast, and especially Saccharomyces boulardii. We will speak a little bit more about it. So the beneficial effects of probiotic on the digestive tract have been confirmed for acute viral gastritis, antibiotic-associated diarrhea, and traveler's diarrhea, using especially these 2 probiotics, Lactobacillus rhamnosus GG and Saccharomyces boulardii for the 3. But it has also been confirmed for irritable bowel syndrome, Uschitis, necrosing enterocolitis, and there is a possible impact also on chronic constipation, ulcerative colitis, cystic fibrosis. The other cases are anecdotal. What are the possible mechanisms of action? It can be a true antimicrobial effect, either by the metabolites produced by these bacteria, such as organic acid, for example. It can be specific antimicrobial compounds like bacteriocins, reuterin, amikumacin for certain bacteria. It could be a competition for the adhesion sites, a restoration of mucosal barrier, a decrease in inflammation produced, the enhancement of immune response, either stimulating immunoglobulin secretion, modulating antigen-presenting cells, or interacting with T cells. So I show you a few examples. For example, first, if you mix Lactobacillus gasseri here with H. pylori, after about 24 hours, you can see here that there are a lot of coccoidal form appearing, and this coccoidal form indicates that H. pylori is dying. And it's the same that you would occur by adding only lactic acid to Helicobacter pylori. The action of bacteriocin can be shown here. You see this is the amount of bacteria. You see with lactic acid, it decreases the number of bacteria. But if you add the supernatant of a culture of Enterococcus faecium, you decrease much more the amount of bacteria of H. pylori present, and this is due to the bacteriocin produced by this Enterococcus faecium. Competition for site of adherence. In these studies, they study the inhibition of biotin-labeled H. pylori, which can bind to glycolipid receptor, acylganglioside GM1 or sulfatide, in black and white, and you can see adding 40 milligram per milliliter, you decrease the binding in an important proportion. If you multiply by 10 the dosage, you don't have any binding anymore. There is also an impact on the mucin exocytosis, a study we performed already a long time ago, showing that compared to control, you see there is a decrease in exocytosis of Helicobacter. Restoration of mucosal barrier. Indeed, H. pylori suppress the MUC1 and MUC5A gene expression, block mucus exocytosis. It can be observed with Lactobacillus plantarum, rhamnosus, which increase the expression of the MUC2 and 3 genes and mucin exocytosis. Decrease of inflammation, you see for this various lactobacilli, which for some of them decrease the ELA production or block the P65 translocation. Another study concerning the impact on EL8 secretion with 4 probiotics. And we did also a mouse studies with 6 batches of probiotics, and the aim was to see the amount of bacteria present in the stomach after treatment with these probiotics. And you can see that compared to control here, there is a decrease in the amount, the load of Helicobacter pylori in the stomach, but unfortunately it was significant only in 3 out of the 6. So the possible benefit of a decreasing of H. pylori load is usually density of H. pylori correlates with the severity of disease. There are examples of overinfection where the decrease of bacterial load decreases the disease occurrence. And also there is a lower rate of inflammation, which may be beneficial to orientate the immune response. So during the Maastricht 6 consensus report, there was, in the working group 5, there was 2 statements concerning probiotics. As you can see, the statement 6 said that the certain probiotics have been shown to be effective in reducing gastrointestinal side effects caused by H. pylori eradication. and this may include lactobacilli and Saccharomyces boulardii. And the other was telling that the beneficial effect may be due to the reduction of antibiotic-related side effects. And it appears that this is the mechanisms to increase the eradication rate rather than the direct effect on Helicobacter pylori. So I show you now the meta-analysis of the effect of probiotics on H. pylori eradication. This study was performed using a variety of bacteria used as probiotics. It summarized 11 randomized clinical trials, and you can see that the eradication rate was better with probiotics, plus about 9%. Compared to the control without probiotics. And the secondary endpoints was to look to the adverse events, shows that there was a decrease in the adverse events when you use probiotics about 13 or 14%. And the impact was mainly on diarrhea. The same type of result concerning Saccharomyces boulardii alone on H. pylori eradication. The first study by Dr. Sayevska used 5 randomized clinical trials, 4 in adults, 1 in children. The primary endpoint was again the eradication rate. You can see that it's 9% better with Saccharomyces boulardii in terms of eradication compared to control. And again, the adverse events were lower using Saccharomyces boulardii compared to control, and it was mainly concerning diarrhea. You can see here the difference between children and adults. There was indeed, it was true for both this group of patients. So Dr. Sayevska did another meta-analysis in 2015. At this time, there was 11 randomized clinical trials that came from more different countries, still the same treatment to which they added the probiotics. Again, the same result with a difference of 11% in favor of Saccharomyces boulardii. And again, for the adverse event, a decrease of adverse event with Saccharomyces boulardii, especially diarrhea. And it was even updated in 2019 by Dr. Zhu, the same type of result, always better eradication and less adverse event. And he also looked to the effect on need for discontinuation, and you see that it was in favor of Saccharomyces boulardii. That means there was less patient to stop the treatment because of adverse event if there was Saccharomyces boulardii in the regimen. So there was also another multi-center study of bismuth quadruple therapy with or without Saccharomyces boulardii to eradicate Helicobacter pylori. It was in Wuhan. This quadruple therapy, they use in this case amoxiclari, esomeprazole, bismuth. Group A, quadruple therapy alone. Group B, quadruple plus Saccharomyces boulardii. And again, there was a small beneficial effect, 82% without eradication, 82.7%, and with Saccharomyces boulardii eradication, 85.8%. And again, same type of action concerning the adverse effects and diarrhea. Interestingly, there was also a benefit of Saccharomyces boulardii on the fecal resistome during H. pylori eradication. This study compared the fecal resistome composition in patients receiving a triple therapy with and without Saccharomyces. They performed a shotgun metagenomics before treatment, as well at the end of treatment and 1 month after. And they showed that the abundance of antimicrobial resistant genes was significantly reduced in the group receiving Saccharomyces boulardii, especially those conferring resistance to macrolides, tetracycline, and a few for beta-lactam, and especially at the end of the treatment. So here you can see the activity of the antibiotic used for H. pylori eradication on the common probiotics that we are using. And you can see in yellow, when the strain is resistant, you can see that unfortunately most of the lactobacilli are susceptible to the drugs used for eradication treatment, except metronidazole. And fortunately for Saccharomyces boulardii, because it's not a bacteria, it's a yeast, it resists to all of them. So the comment is that the problem of probiotics of bacterial type, when they are given with antibiotics, such is the case for H. pylori eradication, is that they are usually killed. And the benefit of this killed bacteria is not so obvious. The big advantage of yeast, like Saccharomyces boulardii, is that it is not susceptible to antibiotic and therefore can still exert its action. So, Mrs. Chairman, ladies and gentlemen, so I think we can conclude that the eradication of H. pylori with probiotics is not feasible per se, but some probiotics may decrease the bacterial load. And the addition of probiotics to eradication therapy improves slightly the outcome, especially with Saccharomyces boulardii. Several potential mechanisms can be involved, but the essential is a decrease in the treatment adverse event, especially diarrhea, which favor a beta compliance. To finish, I just to remind you, if you didn't know, if you know, that the European Helicobacter and Microbiota Study Group will meet next year in Anvers in Belgium in September, and that we have a new journal, Microbiota in Health and Disease. Thank you very much for your attention.
Thank you, Professor Mégraud. I confirm that meeting is a good meeting, and they have every year different city in Europe. Nice to go. So we keep Q&A at the end. So I'd like to now invite the second speaker, Dr. Monthira Maneerattanaporn, and she's from Division of Gastroenterology at Silat Hospital, and she completed her fellowship in motility neurogastroenterology at University of Michigan, and she will speak to us today on the role of probiotics and on the treatment of GI tract diseases. So please, Dr. Monthira.
Thank you very much, Professor Varocha, for introducing, and also thank you, Professor Varocha, for inviting me to join this session, and also Biocodex and DKSH in Thailand to support this symposium. So my role today is to focus about not general probiotics, but only Saccharomyces boulardii in GI diseases. And agenda today is I'm going to talking about Saccharomyces boulardii in GI diseases, including acute infectious diarrhea, antibiotic-associated diarrhea, and irritable bowel syndrome. And also we are talking about a field study that we conducted in Thailand regarding Saccharomyces boulardii. First of all, when talking about Saccharomyces boulardii in GI diseases, Professor Francis talking about the mechanism of action of probiotics already, but I would like to focus here that you can see that these probiotics have pathogen binding inhibition, have antimicrobial peptides, also have immune modulation, and have trophic effects. Some of them we don't have clear mechanism of it yet, but there are few studies that we collect together and look at the mechanism of them, how they can work on our gut. So next slide is to talk about the probiotics in acute onset infectious diarrhea. So this is the mechanism of probiotics for enteric infection. If we have probiotics, that means here is the green one here is a probiotic that we give to the patient, and it can be antagonism to pathogen. So they can inhibit some pathogen, not going to our mucosa. And if even the bacteria or pathogen enter the mucosa already, some of probiotics can kind of moderate your immune to resist to this injury. And also some of them can exclude the pathogenic bacteria from our gut. So let's look at the result of the probiotics in terms of efficacy in prevention of acute diarrhea. So initially, in this study, it was published in 2006, and they would like to evaluate the evidence of probiotics in the prevention of acute diarrhea. And most of them were conducted in a developed country in a healthcare setting. And this study showed that probiotics significantly reduced antibiotic-associated diarrhea by 52% and reduce the risk of traveler's diarrhea by 8% and reduce acute diarrhea of diverse causes by 34%. Also, the probiotics reduce the associated risk of acute diarrhea among children up to 57% and in adults by 26%. And in this meta-analysis, there are sum up of many kinds of probiotics, including Saccharomyces boulardii. And if you look at another paper published 4 years later in 2010 by Cochrane collaboration, they study about probiotics for treating acute infectious diarrhea and have 63 RCT in this study and up to 8,000 participants. And of these, most of them, around 65% of the population are infants and young children. So this indicated probiotics more initially used in children more than adults, but then right now it's developed to a wider market and have a benefit in adults as well. And in this meta-analysis, it was various in terms of definition used for acute diarrhea and definition of the end of diarrheal diseases. However, they found that it was no adverse event were attributed to the probiotic intervention. And also probiotics decrease duration of diarrhea, although the size of the effect different from different study. The summary of this meta-analysis showed that the average of the effect was significant benefit in terms of mean duration of diarrhea decreased up to 1 day. It may be not very, it's not a long duration, but if you look at the children or young adults, it will be very useful for them, especially in infant. 1 day for diarrhea is not bad, not good for infant and young children. And even in adults like us, if we have to go to work and we have diarrhea, 1 day is also important. Also, they reduce diarrhea lasting more than 4 days with the risk ratio of 0.4. And the stool frequency on day 2 is also decreased around 1 time per day. And if you look at specific for the S. boulardii, this is 11 RCT and up to 1,000 patients, all are children, however, and the results show it favor the probiotics better than control with reduction of around 1 day of the duration of diarrhea. And at the 3rd day of diarrheal symptom, these 9 RCT with the probiotics S. boulardii significantly reduced the risk of diarrhea at the 3rd day of illness. So another aspect, like I said, that most of them was conducted in children in acute diarrhea, but in this case, they conducted in critically ill tube feeding patients compared between SB and placebo. And this is a multi-center randomized double-blind placebo-controlled trial and have subject up to 100 cases from 11 ICU in a teaching and general hospital. Subject was there were critically ill patients and supposed to have tube feeding up to 6 days. And the dosage of S. boulardii in this case is 5 milligram per day for 4 days. 500 milligram 4 times a day. And this study showed that S. boulardii can reduce number of days with diarrhea around 28% compared to placebo. Next condition there is traveler's diarrhea. This is an RCT. Actually, this study was conducted by giving the subject with for intervention, but just only S. boulardii that have the effect that can reduce number of diarrhea from 40% to around 30% with both 250 milligram and 500 milligram per day. And the medication or the probiotics was given around 5 days before the departure in up to 2,000 cases of healthy volunteer or healthy tourism. So this is a kind of old study, and they have a meta-analysis later in 2007. This is a 12 randomized controlled treatment of prevention of traveler's diarrhea by probiotics. And there are various kinds of probiotics like lactobacillus, GG, or many kind, and most of them this is a for study that conducted using S. boulardii with a different dosage, and it tend to have a positive effect in terms of prevention of traveler's diarrhea. Next, I was talking about antibiotic-associated diarrhea. So we are GI doctors, and we are well known about the pathogenesis of CDI already, that when you give the patient with antibiotics, any antibiotics, for example, to treat pneumonia or something like that, and that's mean we are going to make a disruption of normal microbiota. And if the disruption is big enough, it might give the opportunity to the pathogen, for example, C. difficile, to colonization and growth a lot. And if they produce the toxin, release the toxin into our GI tract, and initiate to have inflammation, and then have a pseudomembrane or the result of mucosal injury later. So the microbiota will give to the same mechanism like we said before, that to prevent or to protect our mucosa to be more balanced. And this is the study to show, to compare between SB and placebo. Is a double-blind placebo-controlled trial. This was to determine the safety and efficacy of SB in prevention of AAD. In this study, they have a beta-lactam-associated diarrhea, and they recruit almost 200 cases who received beta-lactam antibiotics without diarrhea initially, and then they gave SB compared to placebo. This was given within 72 hours before antibiotics, and up to 4 days after stopping antibiotics, and follow up for 7 weeks. And if you compare between safety and adverse reaction, you can see that SB seem to have less reaction or adverse effect in terms of gas and fever. For the efficacy, this is Kaplan-Meier curve to show the probability of developing AAD between placebo and S. boulardii. And you can see that at 7 weeks, the Kaplan-Meier curve show that the probability of the developing AAD is reduced in SB greater than placebo with the RR of 0.29. And what about the prevention of AAD? This is a prospective double-blind control study. They collect the percent of diarrhea compared between placebo and SB. And at the enroll, you can see that around 180 cases of the patient, and in group of placebo, they have more diarrhea compared to SB. This is different significantly in no NG tube as well, because prior I talked about the NG tube feeding ICU patients already, but also in no NG tube feeding as well. Unfortunately, the C. difficile positive is not significantly different, although it tends to have less diarrhea in group of S. boulardii. And this is the meta-analysis to see the protective effect after treatment of S. boulardii or placebo for the prevention of AAD in adults. This published in World Journal Gastroenterology in 2010. And the conclusion is that boulardii had a significant therapeutic efficacy for the prevention of antibiotic-associated diarrhea with the RR of 0.47. Then JAMA in 2012 published another meta-analysis to see the probiotics for the prevention and treatment of AAD. This is a systematic review and meta-analysis, and there are 63 RCT in trials to report the number of patients with AAD, and they have up to 10,000 participants and indicate a statistically significant association of probiotic administration with the reduction in AAD with the relative risk of 0.58 with the NT of 13. This is overall of the study result, and there was no evidence of publication bias. However, there are existing of significant heterogeneity in a pool result because there are different kind of probiotics. But if you look at the S. boulardii itself, they have 15 RCT in this meta-analysis. When separate to analyze with it showed that they also have a pool result of relative risk of 0.48 in terms of prevention of AAD as well. And the effect can see both in the group that have antibiotics for infections in adults and antibiotic as part of eradication therapy in adults as well. So there are many indications for the antibiotics, and both of them seem to be better if you, have a prevention of diarrhea associated with diarrhea with that case. Okay, what about C. difficile itself? This is a Cochrane database in 2013. The objective is to assess the efficacy and safety of probiotics for prevention of Clostridium difficile associated diarrhea or C. difficile infection in adults and children. The conclusion is that based on this systematic review and analysis of 23 randomized RC3, moderate quality evidence suggests that probiotics are both safe and effective for prevention of Clostridium difficile. Actually, there has been changed the name to be Clostridoides difficile several years ago already. And if you look at particular probiotics, there are overall the result is favor probiotics, right? But if you focus to S. boulardii, there is also heterogeneity, although part of them seem to be benefit in terms of prevention of C. difficile infection in adult. So this is an indication to use probiotics for prevention and treatment of diarrhea. So you can see that evidence the support to support this is different from indication to indication. Like in acute infectious diarrhea, in terms of treatment, and in acute infectious nosocomial diarrhea seem to be have a strong evidence to support it. AAD seem to be in terms of prevention, not treatment. C. difficile associated diarrhea is prevention as well. The treatment is still plus or minus. And for necrotizing enterocolitis, which is most of them happen in children, is also in terms of prevention. So this give us some insight that probiotics can give more balance of gut microbiota, and because we deal with antibiotics, and that's why S. boulardii, which is not bacteria, can survive with that. So let's move to the probiotics in irritable bowel syndrome. We know that the IBS have many pathogenesis, and part of them have the alteration in the gut microbiota, like a post-infectious IBS, alterations in quantity of the gut microbiota, and also the composition of gut microbiota. And this is a randomized double-blind placebo-controlled trial of S. boulardii in IBS in terms of effect on quality of life. In some part of quality of life, there are improvement like interference with activity, social reaction, and overall effect. So there are some benefit in terms of quality of life in IBS patients by using S. boulardii. And the World Gastroenterology Organization Global Guideline in 2017 suggests that you can use S. boulardii to help with improvement in IBS quality of life score with the standard dose is around 250 milligram twice daily. What about in Thailand? Actually, we have a field of study, but I choose two of these. One is not in medical field, but I think it's interesting because they this group of researchers, they select many kind of probiotics to do format what I call biotransformation. Different kind of lactic acid bacteria and S. bullidii to look at anti-salmonella and antioxidative properties. And they use mixed food juice used as the basic medium for microorganism growth. And they're going to use it as maybe like a commercial, because they also test for the taste of the juice as well. And the outcome that they are interesting is to look at the antioxidant activity and anti-salmonella potential and inhibition of biofilm formation. And what they found is that they use many kind of combination here. Like you can see the FP mean L plantarum, S mean Lactobacillus salivarius, and maybe combination, for example, L plantarum plus S. bullidii, L salivarius plus bullidii. And if you look at the combination here, it seems to be that it have antioxidant activity of probiotics of the combination with containing with S. bullidii. And also anti-salmonella potential and inhibition of biofilm also can be found in S. bullidii containing combination as well. So in this study, they conclude that S. bullidii can be used as a starter culture and also lactic acid bacteria, some of them. And the results show that the mixed fruit juice was a suitable substrate to promote the rapid growth and high survival rate of lactic acid bacteria and S. bullidii. And all three of the probiotics fermented juice exhibit antioxidant and antibacterial activity against S. bullidii, Salmonella typhi. So I think this is interesting. Another study was conducted by Professor Varocha and his team, compare between 7 and 14-day moxifloxacin dexlansoprazole-based triple therapy combined with probiotics for HP eradication in Thai patients with non-ulcer dyspepsia. This is a RCT which have 4 arms, including 7-day probiotics, 7-day placebo, 14-day probiotics with SP, and 14-day placebo. And this is the standard, moxifloxacin, dexlansoprazole, and clindamycin. And they also look at another outcome, for example, CYP2C19 antibiotic susceptibility test and CAG-A genotypic. And the successful eradication was defined by negative UBT, which is a standard definition. Even the result of the 7-day and 14-day is not different between regimen, not significantly, but you can see that the adverse events according to 14-day regimen seem to be better when you add probiotics here. So like Professor Francis talked about the probiotics before, that it can reduce the side effect of antibiotics, and this might have to increase the eradication rate. Okay, and in our Thailand consensus on H. pylori treatment, which the chair of the committee is Professor Varocha, state that probiotics, including Saccharomyces boulardii, may be used as an adjunctive treatment in H. pylori eradication to reduce the side effects of the antibiotics. And Professor Varocha and Dr. Varocha also have recently published in JGH Open and say that probiotics are used as an adjunctive treatment to reduce the side effect of antibiotics, which may further increase tolerability and enhance the eradication rate. And also in vitro and vivo study demonstrated that Lactobacillus bifidobacterium species and Saccharomyces boulardii could exert an inhibitory effect on H. pylori. Okay, and this is my last slide, and thank you for your attention.
Thank you for your excellent talk. So we welcome any Q&A from the floor or from online. Okay, so I have a question for Professor Mégraud. There tend to be a shift of a role of susceptibility tests even before primary eradication, but I think in certain group you cannot do in anyone above 50. So more of a test and treat instead of do antibody. So is it possible to do this pre-treatment susceptibility? You talk about the PCR, but that require endoscopy. So you think there is any non-invasive mean and whether it will come in the near future to decide teletherapy to avoid antibiotic resistance?
Okay, I understand that the question concerns those who don't deserve to have an endoscopy. That means those younger than 50.
Exactly.
For example, so what can you do? You can use bismuth quadruple therapy because for this therapy you don't need to test antibiotics. Another possibility, which now is rising and maybe more common in the future, will be to test for clarithromycin in stools. And at this stage is not perfect, but you may need a result in 80% of cases maybe. In this case, if there is a susceptible strain, you can still use optimized triple therapy with clarithromycin amoxicillin.
And
but also, because we are in Asia, if you have a possibility to use vonoprazan, the possibility also is to use vonoprazan with amoxicillin. I think with a good dose of vonoprazan, I may not agree with Ken Sugano telling that you should decrease the dose of amoxicillin because in Europe we have tendency to increase it in contrast.
Maybe online question to Dr. Monthira. Would you recommend the probiotic treatment in nosocomial diarrhea?
Okay, like I said today, that the treatment itself is not a strong evidence. You can use an adjunctive, but it's not a standard yet. But I think the prevention is a more stronger evidence to use it. I didn't mention about the cost though. So I think it might be better in case that they have a kind of high risk to relapse of the antibiotic associated diarrhea. It will be benefit on that case.
Thank you. Question to perhaps Dr. Mégraud. You talk about concurrent use probiotic with eradication regimens. Would you continue probiotic after eradication complete, and for how long?
No, I think you should give probiotics only when during the treatment. I don't remember seeing a study where there was a benefit to keep the probiotics long time after the end of the eradication treatment.
Any comment, Dr. Monthira?
I would like to ask Professor Francis about, I think the guideline that we are mentioning, I think that each countries have their own, antibiotic resistant pattern. So I know that they are very important to have our own data in terms of antibiotic resistance. So I'm not sure if you think that, in Thailand, I think sequential therapy is also still effective. So I'm not sure if you think the talk that you're talking about, the guideline, the consensus can be applied all over the world. What would you say?
yeah, it's difficult to be sure that it can be applied everywhere. No, because there is another reason that you don't have the same drugs everywhere, and also the resistant pattern are different from one country to the other. So I would not say that we must apply all the European recommendation everywhere in the world. But concerning the sequential treatment, I think in Europe we abandon it. We abandon it because doesn't do a better, give a better result compared to the optimized triple therapy. And you add another antibiotics, and so I think now we should consider not only the effectiveness but also the safety with regard to the destruction of the microbiota and acquisition of new resistance among the bacteria in the gut. So this we did at the beginning, we didn't consider at all this kind of events, but now I think it's important to consider. So less antibiotic you give, better it is. I mean, in terms of numbers, at least.
Thank you very much.
If you don't have resistant data in certain country or location, is there any way you can design to avoid like eradication failure?
If you don't have any data, as I showed you, is to use the bismuth quadruple therapy.
Bismuth.
Because bismuth has no impact, not so much impact, in fact, on resistance at least. Tetracycline is not so much used in medicine now, is more in the veterinary or alimentary products. So I think, and metronidazole is not relevant. You can have resistance, is not relevant in clinical.
What about PCAB regimen? Can it overcome?
I think PCAB it's really a progress, because with PCAB you will be able to avoid to give only one antibiotics probably. Yeah? And there are some studies showing, at least in this part of the world, that you can use amoxicillin alone as only antibiotic with PCABs.
Okay. So I think we have learned a lot from the two speakers, and I thanks again Bangkok and DKSH for support this educational program, and thank you very much for both of you. And I think